Hi everyone, and welcome to another episode of Meet the Experts. So I'm delighted to have the fabulous Amy Stein with me today. She's going to be talking about her new book, Beating Endo. Now, if you're working in the world of women's health or pelvic pain, subtle, you're going to know the name of Amy Stein, because Amy has been representing, I think, particularly our profession of physio internationally, you know, through her work in the media, her books, her presidency of the International Pelvic Pain Society. She's always been there representing us. And, you know, you'll have heard me talking about these two before, you know, Amy's original book, Healing Pelvic Pain, and the fabulous DVD that goes along with it, Healing Pelvic and Abdominal Pain. But I was super excited when Amy said that she was writing a new book called Beating Endo with, again, the wonderful Dr. Iris Orbach as well, the endometriosis excision specialist. So I reached out to Amy and I said, we have to have you on to talk about this book because, you know, I'm going to read a little bit off the back cover of the book, Amy, if that's okay.
Sure.
And then I'll let you get a word in as well.
Oh, please.
Approximately 1 out of every 10 women has endometriosis, an inflammatory disease that causes chronic pain, limits life's activities, and may lead to infertility. But the average woman may suffer for a decade or more before receiving an accurate diagnosis. And once she does, she's often given little more than a prescription for painkillers and a referral for the wrong surgery. This book is so important because I think it does a lot of myth busting about endometriosis. I mean, 1 in 10 women, and then it gives a path out of the wilderness as well and a plan for living well. So Amy, well done, amazing book. I think it's going to be essential reading for women who have endometriosis and for the healthcare providers who serve them. What inspired you to write the book?
Well, to be honest, my strength is physical therapy, but I know that there's so much more needed with regard to education amongst patients, amongst healthcare providers, amongst the general community. Yeah. And that inspired me was my patients and my colleagues like you that are saying we just need to get more out there. People need to know that physical therapy can be extremely helpful in a lot of pelvic health cases, including endometriosis. And that's what inspired me. Iris Orbach, Dr. Iris Orbach, she came to me 3 years ago and she said, what do you think? And at the time I was president or about to be president of the International Pelvic Pain Society. I said, not right now. A lot going on with that, and that was super exciting experience as well, but definitely a time commitment. Yeah. And that's what inspired me was my patients, colleagues like you and Iris Orbach to really have a better understanding of how to treat endometriosis comprehensively, because that is the key, is treating it as a whole. What we find, and I'm sure you do the same, Michelle, is that you can't just treat one part of it. You can't just do the PT if the endo is the primary driver of the patient's pain. You can't just treat the bladder if the endometriosis is the primary driver, or vice versa. If the pelvic floor muscles or abdominal muscles are also one or some of the primary drivers of endometriosis, you can't just do surgery and expect a full recovery. The whole picture needs to be looked at, evaluated, and treated.
Yeah, I think the book really captures, and I think it's a difficult thing to do. It's appropriate for both women with endo, but also their healthcare providers. So can you just talk us through the ideal treatment strategy, because I think we're probably all familiar with the less than ideal treatment strategies. Yes. What for you is the ideal treatment strategy and healthcare team to help a woman with endo?
Well, ideally that's a hard question because you really have to look at the patient's symptoms. So we'll have some patients, you know, and the research shows that a patient could have stage 1 endometriosis and have 10 out of 10 pain. And then you have a patient that has stage 4 endometriosis and has no pain, or maybe just has bladder symptoms. So it's really important to look at the patient individually and figure out what are the primary drivers of their pain, or treat what you think are the primary drivers, as well as look at the patient really from head to toe. So what are their eating habits like? Does that affect their symptoms? Do they have GI symptoms that are affecting their overall symptoms and pain? Are there bladder symptoms that the patient's experiencing, and how are we going to address those? So then there's the urologist. You definitely need a endometriosis MD specialist as well, of course. In our practice, we sometimes are the quarterback, per se, of the patient's care. The patient comes to us, we try to help them differentially diagnose and try to help point them in the right direction. And then once we find that team, then we work closely with the team to try to get the best care for the patient. So if it's the PT finding the Iris Orbach or another excision specialist, and it's definitely excision specialist because that definitely works much better. And according to Iris, and the recent research, that is the key to treating to any surgery for endometriosis. And then having a urologist that's familiar with endometriosis, ideally, having the nutritionist to address the GI issues, and or the GI doc to direct, is there an infection going on, an intestinal infection? Is there SIBO, which we talk about quite a bit in our book? And then the mental health part. All this, just talking about it right now, it's overwhelming. And I can only imagine what the patients are feeling, and they don't know what to do or where to go. So really finding that quarterback.
Yeah, and I think, Amy, that's a really valuable point, because so many of these women have been brushed off for years. You know, we know it takes many, many years sometimes to get to an accurate diagnosis, because, you know, they're taught that painful periods are normal, just have a glass of wine and relax, that painful sex is normal. And it's often, I think, you know, it's often down to healthcare professionals like you who are able to kind of, you know, put the pieces together, because, you know, I think it was Chung who talked about the evil triplets of pelvic pain being endometriosis, interstitial cystitis or bladder pain syndrome, and pudendal neuralgia. And sometimes I think as physios, we're in a really good position to kind of look at maybe seemingly disparate symptoms and be able to put a big picture together. So I think this is a fantastic evolution for our profession, that we're seeing that kind of quarterback role, you know, as you put it, really almost as kind of a gatekeeper in a way for a lot of the different streams of treatment. Because as you said, you know, if you're not getting excision and pelvic rehab as a bare minimum, your possibilities are quite limited in terms of recovery, that quality of life.
Right.
Yeah. So I wanted to just read, there's a couple, you know, I really love the book. You can see all the pages I've marked, but there was a couple of really key points that I wanted to bring out. So this is
everyone that's listening, you can buy it now on HarperCollins. And if you put in, I think it's Beating Endo, you get a 20% discount. It's coming out June 25th.
Perfect.
Which is in a couple weeks, but it's pre-sales now. So definitely, this is the final version. You have the original, Michelle.
Worth a fortune.
Yes.
Priceless. So there's a chapter in the book about the key to beating endo, and you talk about Nancy Peterson, the founder of Nancy's Nook, in there, and how Peterson has spoken about the anger and sense of victimization patients can feel when the system fails them, and about the need, as she says, to get past it. And once you do, she also reminds patients there's no single magic bullet for endo. Meds do not treat endo, Nancy stresses. They treat the symptoms only. Rather, each co-condition, each generator of your pain, discomfort, or dysfunction must be addressed with its own treatment plan. For example, you cannot remove endo and expect pelvic floor dysfunction to fully resolve. Can you talk to us a little bit about the sort of pelvic floor dysfunction that we're talking about with these women who are going through endometriosis?
Sure. So what we see is it's sometimes hard to tell what's driving what. Did they have pelvic floor dysfunction initially and the endometriosis, maybe it was a stage 1? It was just contributing to some of the pelvic floor or abdominal issues. So that's a great question. It's a hard question to answer, but the positive thing is we know how to treat. So what we do as physios is we look again from head to toe. We really need to evaluate really the whole trunk area. We need to watch how the patient's walking, because if their gait is off, it can have a ripple effect. It could affect their pelvis, their alignment, and then it can cause pain. So the pelvic floor muscles and the abdominal muscles, some of the abdominal muscles, are part of your core muscles, and you need that for stability and mobility. And if there's a dysfunction in any of the core muscles, it can have a ripple down effect the other way and can affect the knee or the foot. So it's really important to look at the whole body, but also then hone in on, are there trigger points in the abdominal wall that are contributing to the patient's pain? Are there trigger points in the pelvic floor, in the back, in the glute area that are contributing to the patient's pain, or bladder symptoms or bowel symptoms? It's also ideal, and I know not everyone can find this, but if a pelvic floor therapist also looks at the viscera, and they do visceral mobilization, that's another key to helping with endometriosis pain specifically and symptoms, because sometimes the bladder is stuck on one side, whether again it's from musculoskeletal, like a trigger point, or a nerve irritation that's irritating the surrounding area, or whether it's the bladder that's been inflamed for, a month or 2 months or a year. Or is it an endo implant that's actually physically pulling on the tissue, pulling on the connective tissue, the bladder and the muscles? So it's really important to look at everything from top to bottom, from kind of out to in.
And I think as well, even after somebody has had excision surgery, there will be some adhesions from the surgery itself, right, that can also cause some ongoing issues.
Yes.
How do you feel, because obviously with that chronic exposure and misdiagnosis and not being listened to for years and years, that's obviously got to cause a lot of mental stress and central sensitization of the nervous system as well, which I suppose can lead to a little bit of a fear of movement then too, So how do you get around that? What do you see as an ideal strategy to break that fear of movement and to start, kind of opening up the possibilities in terms of returning to exercise?
That's a great question. And to go back to your first point about you really need to work with the patient pre-op and post-op. So in our book, we actually talk about how Dr. Orbach doesn't want to do surgery on a patient until their system is as down-regulated as it can be. Meaning what happens with all these things, again, some people have 5, 6 symptoms going on. Some people have 1 or 2, but really trying to calm those other symptoms down and then do the surgery is ideal, because if your system is so sensitized and flared, then going into a surgery, it's going to be sensitized and flared, and coming out of it, it can be even more. So the pre-op is just as important as the post-op. And like you said, the post-op is really important because of potential adhesions or trigger points that may resurface, or nerves that may get irritated from the procedure itself, or from not moving as much. And that's where there's a term called kinesiophobia. And it's really, again, that quarterback needs to step in and really give that patient confidence that you can move again. You need to move. And we're going to figure out how you can and what works best for you. Because for you, maybe swimming is best. Maybe in Ireland, having a umbrella and walking around in the rain makes you feel happy, and or in New York City, walking around the buildings, the concrete jungle. So it really is dependent on the patient, and just even getting that, starting off pre-op or post-surgery, that 5 minutes 3 times a day of just walking around. Like, I'll have patients that they come in pre-op and they can't even walk across their apartment building. And I'll even just start there. Like, you got to start somewhere, or yoga. And then, sorry, I'm talking a lot, but, and then to address the central sensitization, which we do in the book. Yes. That's basically what that is, to explain it to everyone. It's just the system gets oversensitized. So you have the endometriosis that could be affecting your symptoms. Then you could have the bladder, or the GI, or the pelvic floor, and the dial of symptoms gets turned up, and your system gets sensitized. So by dialing the system down and addressing the individual areas, and I know it's overwhelming, but as Michelle and I can tell you, you really at the beginning need to do it all, but then after a while you'll see, oh, okay, I got the diet down. Now I can exercise 45 minutes a day, no problem. I don't need to go back to my GI doc anymore because I got, that under control. So it seems a lot at first, but then you can get there. And one of the keys, as I mentioned in the book, is turning down that dial, and that central sensitization is a key to recovery as well.
Well, what I like about the book, Amy, is that it very much embraces the notion of, control your controllables. What can you do at this point? What can we do in terms of stress management? Can we find a movement strategy that you enjoy? And yoga, Pilates, walking, swimming, whatever it is that you enjoy. Because, wouldn't it be fair to say that if you're having excision surgery, the better shape you're in physically and mentally, the better shape you are going into that surgery, the better your outcomes are going to be afterwards.
Yes, exactly.
So, it's about making that commitment to self-care.
Yes.
Yeah.
So similar to, and I don't want to compare the two because they're not really comparable, but if you were to have ACL surgery, knee surgery, or shoulder surgery, the physician ideally wants you to be in the best shape you can be before you go into the surgery, with your muscles being as strong as they could be, so that when you come out of the surgery, the rehab is actually less and more tolerable, and you're in better shape, so that when you have to go ride a bike for 20 minutes, you've already been doing it for 45, and you can tolerate that 20 minutes of cycling.
So you're doing your prehab as well as your rehab.
Your prehab and your rehab and your post-hab.
So another thing that I like about the book is, you can probably see here in these pictures, but a lot of books and a lot of info out there about women's health is you should do this, this, and this, but they don't actually tell you how. And I thought it was really great that actually you have pictures of stretches, of actual real life scenarios. So you're taking it from, kind of abstract, oh, you need to eat better or you need to exercise more, to no, eat this, avoid this, do this stretch, avoid this exercise, don't do this, but try this and see how it works for you. So it's not one size fits all. There's a menu of things that we know work well for a lot of women with endo. What are the, if as a physio, if we were talking to physios here at this point, what are some of the key things that as women's health physios we need to be looking out for that might kind of get our wheels turning a little bit to think, could this be endometriosis?
That's a great question. So a lot of the questions we ask are, do you have painful periods? Have you had painful periods? When did it start? When did those symptoms start? What other symptoms do you have? Because we do see a close correlation with some GI issues and or bladder issues. So really asking the patients a lot of questions about that. We also see sexual health challenges with our active adults. So really asking the questions to the patients, also seeing what they've done and what they've tried before. Like, does birth control pill help with some of your symptoms? Do NSAIDs or anti-inflammatories, do those help at all? So anti-inflammatories can help with musculoskeletal symptoms, but it can also help with some of the pain that endometriosis can cause. So there's that differential diagnosis that can be challenging, but as a PT, you have to keep looking, have to keep investigating. Sure. It's a lot of repeated questions to the patients because you want to know how they responded to the PT. Did they flare? Did they get better, which is a good sign, that because we're addressing more the musculoskeletal system. So if they're seeing benefit, then it's clear to me that there's a musculoskeletal component, which with most of our patients, there is a musculoskeletal component. Yeah. But if there's certain things that aren't getting better, their painful periods still happening, they still have that GI issue, even if you've worked on the viscera and the pelvic floor, they change their diet, they're still having pain, or they're having deep penetrative pain with sexual activity that's just not going away. And definitely, if there's still the painful period, putting that picture together is important. And I've learned a ton over the years from my patients and health providers like Iris Orbach, because in the beginning of my career, which there wasn't as much education on pelvic health as Michelle can attest to, Michelle is one of the amazing teachers of it. I wish she were here in New York teaching, but that's my own bias. We've really come a long way, because I didn't realize 20 years ago what specific questions to ask for. But now that I've learned from, again, patients and colleagues like you, I'm able to figure out, okay, bladder symptoms aren't getting better with the urologist, and maybe they're getting bladder installations or whatever, and the PT. There's something else going on. Let me send them to an excision specialist.
Yeah. Okay, so let's do a little bit of a true or false here, Amy. Okay. I really like this section in the book. Birth control pills can cure endometriosis. True or false?
False. They can help with the symptoms of endometriosis. There's some literature out there saying that it can help to minimize the advance of endometriosis, but there's other literature saying that it doesn't. So I think the verdict's still out. It's hard to tell, because we don't want to go in and do surgery multiple times on these patients to see what's happening inside. So the verdict's still out there if it can help to slow down the progression.
Yeah. Okay. But ultimately, it's not really treating the disease. It might calm down the symptoms, but the disease progresses. Okay. So true or false? Ablation is as good as excision.
False. Ablation only gets the surface. Excision actually excises the whole implant.
Yeah. So it's more of a treatment rather than just removing the top layer. Okay. True or false? Hysterectomy is a good treatment for endometriosis.
False. Because as we know from the research, that a lot of the cells are outside of the uterus. So if you're taking away the uterus, the cells of the endometriosis are still there.
Yeah.
So
Plus then women have to deal with the after effects of hysterectomy. And if the ovaries are removed, you're looking at an increase in all-cause mortality and cardiovascular risk and bone health and brain function. So you're actually really increasing her potential level of disability and possibly even early death. So I think that's a really key point that we need to get across. And true or false, laparoscopic excision.
Plus you're also getting all the hormonal changes happening.
Absolutely. A fairly harsh menopausal transition. Okay, so true or false, laparoscopic excision followed by pelvic rehab is the gold standard for treatment of endometriosis.
True, but you need to do the prehab, and you also need to address the GI, the bladder, so you may need a nutritionist, mental health therapist to help calm the anxiety and stress that may be going along with it.
Yeah.
You need, if there's bladder issues still, you may need to visit a urologist to address those. If there is pudendal neuralgia, a lot can be done through physical therapy, but you may need a pudendal nerve block or something else to help lessen the pain, help down-regulate the whole system. So,
yeah, I think that's a really important point, because so many women, I think, you know, they're so happy once they finally find an excision specialist and they have the surgery, and they wake up expecting everything to be gone, and you know, their whole lives are back to normal again. And I sometimes feel that that's really the start of their journey, you know, and it's the foundation, and then we have to help them build on that to get back to a good quality of life. Amy, you know, I just think that if you are working with women, particularly in the field of pelvic health, this book really will be it's an excellent primer on everything that we should be aware of, but a lot of us aren't when it comes to endometriosis. So it's out on the 26th of June, coming up very soon. HarperCollins, Amazon, Barnes & Noble, wherever good books are sold.
Yay!
And for your...
Yeah, I was going to say, if they want further info on the whole self-care part from a PT perspective, because I do, the book goes over, kind of touches on everything in general. Healthy bladder habits, healthy bowel habits, how to find a proper surgeon, how to address the nutrition, the central sensitization, the mental health. If they do want to look more into the exercises that you were advocating, these do have more of the self-care from a physio perspective.
Yeah. And I think that's really important, because it can be quite overwhelming. And if you just say to your patient, go do yoga, go do Pilates, you know, it's not really every style of yoga or Pilates that's going to be suitable, because we want to focus maybe more on strategies that are going to lengthen and strengthen rather than tighten. So important that you've got a good teacher. And, you know, for your home practice, this DVD, I think, is invaluable, because there's so many different, it's a great toolbox of self-care strategies, which is a huge part of recovering from endometriosis. Amy, thank you so much.
And that's a good point, if you don't mind me just addressing that. If you do try yoga and you haven't tried it before, or if you've been doing yoga and you're experiencing more symptoms or pain, it's not that you shouldn't ever go back to it. You may just need a physio to take a look at things. Maybe your sacroiliac alignment is off, or your hip alignment is off, and it's not saying that you won't ever be able to go back to yoga again, but you may have to modify things in the interim before surgery, or if you're having surgery, you may have to try walking instead of yoga, or yoga instead of Pilates. So another thing that I do stress to patients is, don't give up, because there are things we see that there are things that we could figure out with you to be able to do. It's just finding that thing that works for you, finding that thing, and that amount of time that doesn't aggravate your symptoms. So that 15-minute walk, or even that 5-minute walk up and down stairs, getting your cardio system going, but not over stressing other areas by doing a 45-minute yoga routine.
Absolutely. So really, it's about having that kind of bespoke, you know, approach, really, isn't it? That you're tailoring it for the individual woman who's in front of you.
Yes. Yeah. So really working with the patient, listening to them, because if you tell them, go do yoga and they're fine with the yoga, but they don't like it, they're not going to commit. So really, really working with that patient to see what works best for them is key.
Perfect. So if you are in New York watching this, Amy and her team run a series of open evenings where they will share their pearls of wisdom. Amy, where can people find out more about your clinic or follow you on social media?
So we are on social media at Beyond Basics PT. We're on Facebook, Twitter, Instagram, and we're trying to really give out a lot of self-care information and resources for patients and to help guide patients with articles and various resources like the International Pelvic Pain Society. And then we do have a great blog. And in New York City, we are in Midtown, right across from Grand Central Station. And then we are also downtown, which is where I am right now. And I'm actually looking into our downtown office as we speak on Ann and William Street, right near Wall Street and the Freedom Tower, which is right, wait, hold on, don't move. It's right.
Wow.
There's a Freedom. So yes, heart of Manhattan in both locations.
I feel like I should have started, Amy, with live from New York. It's Amy Stein.
From New York. From the Freedom Tower, downtown Manhattan.
All right, 1 in 10 women have endometriosis. So again, essential reading. Amy, thanks so much for hanging out and sharing your view of the Freedom Tower and all that valuable information. But thank you most of all for writing this book, because I think it's going to be incredibly useful to all of us as healthcare providers as well.
Great. Thank you, Michelle. And thank you for all you do. The whole world of pelvic physical therapy couldn't thank you enough, as well as myself and my colleagues. So I hope you come to New York City.
Thanks, Amy. Hope to see you soon.
All right. Take care. Bye.